acute coronary syndromes are also called ACS, current concepts and management of acute coronary syndrome. So the floor plan will be cardiometabolic risk, which we have seen very extensively for about, I think, 3 or 4 classes, cardiometabolic risk. We just summarize that. And then what is the atherosclerotic burden? And then what is the pathogenesis of acute coronary syndrome? What are the algorithms for unstable angina and NSTEMI? And management of unstable angina and NSTEMI. And finally, the classification, STME management, and ECGs in acute coronary syndrome and prevention. This will be the floor plan. Let us start with the cardiometabolic risk. Next slide. So as you can see here, there are only 2 exits from this world, as I have told you earlier also. One exit is the cardiometabolic exit. The other is all diseases put together. 50% of the problems are cardiometabolic. Remaining all causes of death, including accidents, suicides, pregnancy-related infections, AIDS, name anything, it comes under the next 50%. So such is the importance of cardiovascular disease. Next one. So you can just click those things. What is cardiovascular mortality? Is at the end of the show, we have the cerebrovascular disease, peripheral arterial disease, renovascular disease, and also coronary artery disease. Our focus now is on the coronary artery disease. Okay, this is the slide from the American Diabetic Association. So what is cardiometabolic risk? There is one aspect is the overweight obesity complex coupled with genetics and the age. These 3 together produce insulin resistance on the left side. Insulin resistance syndrome increases the lipids, blood pressure, and glucose. All have independent effect on the cardiometabolic risk. Along with the insulin resistance, genetics, age, insulin resistance, lipids, BP, glucose all have an effect on the cardiometabolic risk through overweight and obesity, and also independently also. Abnormal lipid metabolism, high LDL, ApoB more, HDL low, high triglycerides, that also is an issue. Then age, race, gender, and family history, these are the non-modifiable part. Then the inflammation part and hypercoagulation. Hypertension separately has the risk factor, smoking and physical activity also. Let's go to the next slide. Now, we see the atherosclerosis and insulin resistance. How does insulin resistance get translated into atherosclerosis? Through hypertension, through obesity, through hyperinsulinemia, diabetes, triglyceridemia, small dense LDL, low HDL, and hypercoagulability. All these, the forerunner is the insulin resistance. It is for us to pick up the insulin resistance early and treat it so that we can avoid the intermediate steps like hypertension, hyperinsulinemia, and all, and so we can prevent the atherosclerosis. Next, you can see the Dasyavataram there. Next slide. The increased cardiovascular risk. Several factors are operating. It is not one particular factor. Let us start with the insulin resistance on the topmost. Insulin resistance and hyperinsulinemia, dyslipidemia, hypertension, visceral obesity, pro-inflammatory state, pro-thrombotic state, endothelial dysfunction, vascular integrity is damaged, impaired glucose tolerance, and impaired fasting. All have got a role to play for the increased CV risk. Next one, this slide is very familiar to you. We have seen this is where we have closed our last thing. There are modifiable risk factors on the right top, which are the diabetes, increased blood pressure, smoking, lipid abnormality, obesity, increased waist circumference, or physical inactivity. All these are we can manipulate and then positively change those things. And there are non-modifiable risk factors on the left side, which are the age, gender, ethnicity, family history, CVD, and then the personality and the phenotype B, which are the non-modifiable risk factors. And of course, the emerging risk factors are very important. Endothelial dysfunction, lipoprotein A, SLDL, HSCRP, ApoA1/B ratio, homocysteine, all of them together have increased the risk of coronary artery disease. So let's go to the next slide. Coronary artery disease in Indians. This is called CADI. So what is the commonest etiology or combination of factors here? You can say 15% of the Indian CADI is due to high LDL and low HDL. 10% due to hypertension, 10% due to diabetes. Lipoprotein A contributes to 25%. Tobacco usage 10%. Homocysteine 5%. All other risk factors together 10%. What are the most important things? Diabetes, hypertension, high LDL, low HDL, LPA. These are the Indian dyslipidemia. This is called CADI, coronary artery disease in Indians. Now you see. Next slide. The relative risk of coronary artery disease, we have seen this slide earlier. Obesity is the risk factor, dyslipidemia, systolic hypertension, and smoking. Independently, they are. But there are two of them are together. The risk is 1.6, 3, 5, and 6. If three or more are there, you can see 4.5, 4, and 16 times. If somebody is a diabetic, all these are doubled. So diabetes is not there in that four circles. If somebody is a diabetic, every risk estimate is doubled there. So we have to be wary of these things. This slide also, next slide. We have seen that we don't want to treat the patient in the end-stage heart disease or about to die or congestive heart failure fellow. We wanted to tackle at the level of risk factors, endothelial dysfunction, atherosclerosis, coronary artery disease, myocardial ischemia, thrombosis, infarction, arrhythmia, muscle loss, remodeling, ventricular dilatation, congestive heart failure, ESHD. ESHD is end-stage heart. So we as physicians have the bonus not to allow the patient into coronary thrombosis, myocardial ischemia and down. We have to prevent somewhere before that at the risk factor state or in the endothelial dysfunction state and the atherosclerotic state. Next one, you see. Next slide, we have this loop here, cardiometabolic risk, like CMR you start, then you have got the LVH, left ventricular hypertrophy, coronary artery disease, ischemic heart disease, silent, anginal, hibernation, ischemic heart disease progresses to acute coronary syndrome, acute myocardial infarction, LV remodeling, arrhythmia, sudden cardiac death, heart muscle remodeling, congestive heart failure, end-stage heart failure, and finally death. Can we intervene in the first 3 or 4 levels and prevent the end-stage heart disease and death in patients with coronary artery disease? That is the chain of events have to be halted at some point. Next slide, please. So this we have completed the cardiometabolic risk in short. Now I am going to tell you the atherosclerotic vulnerable plaque. This is a very important concept which most of you are not aware, I am sure. Let us see what is this atherosclerotic vulnerable plaque. So next one. Macrophages express the receptors that take up the modified LDL. What is that? LDL is circulating in the blood. The circulating LDL is on the endothelium. This LDL has got no way to get into the subendothelial layer. Unless it gets into the subendothelium, it is not dangerous. What is it that is making the LDL on the endothelium get into the subendothelial layer? That is what you have to. One is oxidation of the LDL. LDL has to be oxidized before it can enter into the subendothelium. What oxidizes the LDL? If there is nitric oxide rich on the endothelium, it cannot be oxidized. If there is no nitric oxide, there will be oxygen radicals will be floating in the blood, and those oxidize the LDL and make it vulnerable to go into the subendothelium. In addition, what pulls the LDL inside is what is called the monocyte. This monocyte is circulating in the blood. This monocyte is supposed to be a useful cell for our body, and there are certain adhesion molecules on the endothelium. These adhesion molecules pick up the monocytes and pull the monocytes into the subendothelium. That is called MCP1, monocyte pathogenic factor, which is one MCP1 protein, and that pulls the monocyte inside. This simple innocuous monocyte is converted into a macrophage. This macrophage is getting big mouth. It will try to swallow the LDL that has come inside, and that becomes a bigger and bigger cell. The monocyte dies and foam cells are formed. A debris of all the cholesterol is deposited in the intima. Okay, what makes the monocyte trigger and get into inside are the adhesions molecules. Where from the adhesions molecules are coming? These are due to the endothelial dysfunction. If the endothelium is good, there are no adhesion molecules. Monocytes cannot get inside. If the endothelium is functioning well, nitric oxide is good, and the LDL cannot be oxidized, it cannot go inside. The entire pathology, entire groundwork is on the endothelial dysfunction. There is another factor called the SLDL and small LDL and LDL we are talking in the vascular lumen. Thus, that LDL first has to be converted into SLDL, small dense LDL, so that it can escape into the endothelium. That SLDL should be oxidized. Modified LDL taken up by the macrophages produces the foam cells and the debris is formed. And once the macrophages are inside the body, inside the endothelium, they trigger several chemokines. which further attracts the monocyte, further oxidizes the LDL and perpetuates the chain. This is how the innocuous LDL, which is circulating in the blood, the good monocytes or friends are becoming enemies. What is the role of HDL? HDL is the one when the LDL is lurking on the endothelium. LDL will go and HDL will go and say, what are you doing here? You are not supposed to be here. You go to the liver, you have to get excreted. LDL, HDL, it will not hear. No, not like that. You come, I will take you. Hold the hand of the LDL molecule, and then this is called reverse cholesterol transport. And then goes to the biliary canal, leaves the LDL fellow there, the LDL goes. Another thing is, there are what are called the LDL receptors, LDLR. These LDLR are not always there in all the vascular beds. For example, radial artery, the LDL receptors are absent. That is why you take the radial graft and okay, in the internal mammary artery, the LDL receptors are not there. So that's the internal mammary artery is used. And cerebral blood vessels, LDL receptors are very much expressed. Coronary artery endothelium, LDL expression is very much. Expression means the receptors are there on the endothelium and they will catch the LDL. Some fellow is going on the road, somebody pulls him up and makes him sit on the endothelium. That is the receptor. So, one person with the same risk factor develops heart disease. Another person will not develop the heart disease. Why? The LDL expression is different. In this person, LDL is picking up and putting it in the endothelium. In the other person, it is not doing it. LDL receptor expression is both genetic and conditioned. That means not only you are genetically prone to have LDL receptors more, if you don't do exercise, if you smoke, if you are having dyslipidemia, LDL receptor expression will increase. Both nature and nurture. So this is the pathology. Let's go further. Next slide. So you see diabetes now. Before that slide, there is one, we have now flashed the diabetes. That means diabetes triples the risk of all this pathology. That is the LDL oxidation, MCP1 expression, adhesion molecules, monocyte adhesion, macrophage formation, all are increased by diabetes. Needless to say, control of diabetes is very, very important. Next, you go to the endothelial regulatory functions. Are you on that slide? Endothelial regulatory functions. You see the green side. Endothelium is such a protective organ. This is the largest endocrine organ in the body. And normally it produces nitric oxide, PGI2, endothelial growth factors, and then CNP. All these are vasodilatory in nature. And they are thrombolytic. And they don't allow the platelets to aggregate. Platelet disintegration. And anti-proliferative for the smooth muscle. Lipolysis and LPL also are expressed by the endothelium. This very beautiful endothelium, we have converted that into a very bad fellow. In the next slide you click. You have the bad endothelium, the red one. The vasodilators are replaced by vasoconstrictors. NO is replaced by reactive oxygen species. PGA is replaced by ET1, thromboxane A2, angiotensin 2, PGH2. Thrombolysis is taken by thrombosis. Platelet disintegration is increasing here on the other side. Adhesion molecules and platelet adhesion. CAM, C-selectin, P-selectin, and other things. Anti-proliferation has become now proliferation, growth factors and all those things. And lipolysis and LPL is now replaced by inflammation. Who is doing this job? Who is converting a beautiful green endothelium into a red and dangerous flaming endothelium? It is all that we are doing is to damage the endothelium. Like in a sedentary lifestyle and then bad eating habits, high cholesterol, genetics, and whatever risk factors you have said, all of them, and smoking, of course, all of them are making the endothelium a very bad endothelium and making it vulnerable for LDL oxidation and LDL entry into the subendothelium. Next one. So, next one is pathophysiology of vascular disease. I am reading the heading so that you see whether you are on that slide. Okay, risk factors. Number one, we know important things: dyslipidemia, hypertension, hereditary, and then smoking and diabetes. Basic ones. Oxidative stress, Jagdine oxidase inhibitors, NADPH, NAD system, uncoupling of the ENOS. ENOS is endothelial nitric oxide. Endothelial nitric oxide should be uncoupled for it to be active. When there is oxidative stress, the nitric oxide is not uncoupled, not ready to handle the oxidative stress. Endothelial factors, nuclear factor, kappa B, chemokines, growth factors, SCAM, ICAM, ACE, enzyme itself, angiotensin II, all are the endothelial factors. Then functional alterations, decrease in the NO, a decrease in the vasodilatation, increase in the vasoconstriction, inflammation, and procoagulant state. And finally, there are certain structural alterations that occur. Increase in the tone of the vessel, smooth muscle cell hypertrophy, inflammatory cells, plaque formation, negative remodeling of the blood vessels, decrease in fibrinolysis, increase in platelet aggregation and inflammation. These are the structural changes that occur on the endothelium. What will the clinical sequelae? Ischemia, myocardial infarction, congestive heart failure, stroke, major acute coronary event, and sudden cardiac death. These are the various stages. Risk factors, oxidative stress, endothelial dysfunction, functional alterations, structural alterations, clinical complications, or clinical sequelae. Next one. Let us see. Now it is very well studied the types of plaques. The plaques are deposits on the inner surface of the endothelium. So just like you have a tube in the house with running water. After 5 years of use, 10 years, there will be crusts will form inside. Brown crust will come. He will say, he will tap the thing, this much debris he will bring out. Sir, this pipe is gone, we have to put a new pipe. Or he says, this part is gone, I remove it and connect with a new junction. Like that, here also same problem. What is this crusting or the plaques? There are 6 types of plaque. Type 1, lipodeposition, macrophages, in the hand smooth muscle activation called the foam cells, which we have seen in the slide. Type 2, extracellular lipodeposit, fibrils, so-called fatty streaks. The third one is called the extensive changes of the type 2. Type 1, type 2, type 3 are still in a stage where you can control the risk factors and positively influence the disease. Then type 2, type 4, type 5, type 6. Type 4 is lipid dominant, cellularity less, vulnerable plaque. Plaques are 2 types, vulnerable plaques, non-vulnerable plaques. Where lipid is dominant and cells are less, it is a vulnerable plaque. There will be the cap of the plaque also will be very thin and anytime it can give way. Compared to that type of plaque which is cellular proliferation dominant, non-vulnerable plaque and lipid is less. Fibrosis and calcification, extracellular lipid. Now, what is type 2 4 plaque and type 5 plaque? A same individual having the same amount of cholesterol, one person will have in the 2 different individuals, one will have lipid dominant type 4 plaque, another will have cells dominant type 5 plaque. Type 5 plaque will not rupture, whereas type 4 plaque ruptures immediately and produces thrombosis and clinically silent or acute coronary syndromes or occlusion. Now, how do I know what type of plaque a given individual is having? Can I know that? By looking at the blood biochemistry, can I say whether he has a plaque? If he has got the plaque burden, what is the plaque burden? If the plaque burden is it vulnerable plaque or non-vulnerable plaque? And what makes the plaque vulnerable? These are the questions. Now you see, type 4 and type 5. Type 4, 5, 6. Next one. Type 4 is the lipid dominant, less cellularity, vulnerable plaque, thin fibrous cap covering the lipid core. Anytime the cap will be open. Type 5, cellularity dominant, non-vulnerable, less lipid, cap is very fibrous and doesn't easily open and maybe getting calcified. That is why calcium scoring of the coronary arteries not always correlates with the clinical disease. When there is calcium scoring, they have plaques, but those plaques are for non-vulnerable. Whereas less calcium score, but patient may develop severe disease because the plaque is vulnerable. Type 6 is ruptured plaque, excites thrombosis, and clinically silent or acute coronary syndrome or occlusion. Now, how does the plaques which are vulnerable become less vulnerable? All major interventions. Diabetes control, hypertension, dyslipidemia control, stopping smoking, exercises, more of polyunsaturated fatty acids, and lack of unnecessary estrogen use should be prevented. If you have all these factors, then the vulnerability of the block can be reduced. Next one. Now, you see, you can diagrammatically see what is a vulnerable block, what is a non-vulnerable block. Vulnerable block is also called the unstable block and stable block. Stable block, you see the lumen, beautiful lumen is there, and the very thick fibrous cap, the brown cap is there. Below that, lot of cells, less of fat. Whereas on the other side, the unstable block or the vulnerable block, there is a very thin fibrous cap, the brown cap, and less cells and more of the lipids are there, and it can excite thrombosis and produce. There is a lipid-rich core. The white one is the lipid-rich core. That is very much there. So an unstable block can give rise to immediate rupture. The chances of rupture are there. Thick fibrous cap, thin fibrous cap. More cells, less cells. Less fat, more fat. Less vulnerable for rupture, more vulnerable for rupture. A mild to moderate atherosclerotic block is more likely to rupture and trigger thrombosis than a severe block. What does this mean in clinical sense? Let us see the next one. Now we have come to the pathogenesis of the acute coronary syndromes. We have seen the risk factors. We have seen how the atherosclerotic block forms and what are the various risk factors for that. Now we see what happens when the ACS is triggered. Next one. The first one, you see the deposit there, that is the block is there, an elevated lipid deposit is there, and there are cells inside. There is the cap is open now. That is called block fissure or rupture. Once that occurs, then immediately platelets try to plug the rupture. The second step is the platelet adhesion. Then platelet activation. These platelets have become active. They pull in more aggregation of other platelets and other thrombogenic materials, clotting factors, everything. A thrombotic occlusion occurs. So what happens? A block which is fissured or ruptured, platelet adhesion, platelet activation, platelet aggregation, thrombotic occlusion. This is a series of events. Now you see in the bottom, non-vulnerable erytheromatous block, very tight fibril cap, it will never rupture and blood flow to some extent is okay, and then demand is met. Whereas vulnerable block, the fibrous cap is very loose, anytime it can rupture and go into the abort. And in the body, the vulnerable block and non-vulnerable block, they will be alternating, they will be changing. A vulnerable block today after 2 years will be non-vulnerable, depending on the intervention. So likewise, a non-vulnerable block burden can suddenly turn vulnerable also. This is very important. Next is, now, it's okay if the small the thrombi are formed, microthrombi, the platelet thrombin microthrombi are formed. These microthrombi, they travel into the distal part of the circulation, as you see on the right side, into the smaller blood vessels and occlude the microcirculation. When these thrombi elicit more thrombus, and as you see the lower part of the blood vessels, the thrombus is obstructing, then acute syndrome develops. Now, there is an embolus, there is second embolus, there is a third embolus. These are small things. But when the diagnostic threshold of the small microemboli has increased above that dotted line, you get what is called acute occlusion and the drop elevation that you see. Until that critical line, you will not see drop. The microemboli is the patient complaint symptoms. This is called microvascular angina. If you look at the blood vessels are not obstructed, but patient will have ST depression and then symptomatic. This one is called microvascular angina. Why? There are microthrombi released from the blocks, one small rupture. When that becomes acute, then this becomes macrovascular disease, and then drop is now elevated. Next one. Acute coronary syndrome. What are the triggering activities of a patient? Triggering activities patients in acute coronary syndrome. Acute risk factors of the arterial pressure surge or vasoconstriction lead to block disruption. Sudden increase in the arterial pressure. Acute onslaught on the blood vessel. Or acute risk factors of coagulability increase or vasoconstriction lead to complete occlusion by the thrombus. Now, what is happening now? A non-vulnerable block now has become a vulnerable, and it has opened the cap. minor plaque disruption, non-occlusive thrombus formation, and going on to occlusive thrombus formation. There will be three stages: minor plaque disruption, that is unstable angina; non-occlusive thrombus, ST segment elevation; occlusive thrombus, and non-occlusive thrombus is NSTMI; and finally occlusive thrombus. Minor plaque disruption produces symptoms: unstable angina; non-occlusive thrombus, NSTMI; occlusive thrombus, STMI. Now, the patient may be asymptomatic, unstable angina, or QA myocardial infarction. And some people, without going into these three stages, from the vulnerable plaque, directly they have major disruption, occlusive thrombus and sudden cardiac death. So, there will be two types of patients. One type of patient who progresses with angina and slowly develops the cardiac symptoms and over a period of occlusive thrombotic disease and then myocardial infarction. Another type of patient who does not give any warning, suddenly the plaque rupture occurs and occlusive thrombosis and produces acute myocardial infarction or sudden cardiac death. Next one. This is a very important study and slide also. Now, every one of us, if I ask you, a patient has got 70% stenosis, another patient has got 30% stenosis, who is at a greater risk? What is your answer? 70%. That's not the case. That's not the case. 75% stenosis with a stable plaque is okay. 30% stenosis with an unstable plaque is more dangerous. This message you have to get it. No, sometimes they do angina. No, 30% only. 30% only, how about the risk factors? If all the risk factors are allowing it to rupture, within no time the 30% becomes 100%. Versus another person who has got 75% stenosis in coronary, and he doesn't have any of the conventional risk factors, the plaque is stable, he exercises, doesn't smoke, the plaque may not rupture at all, and 25% is adequate for him to carry on. He may not require reverse. This is a landmark study to show that it's published in Circulation in 1995. You see, coronary artery stenosis percentage, and then here, Ambrose, Little, Nobashaki, all four studies have shown coronary stenosis severity prior to myocardial infarction. All put together, let us see the last bar. 14% only of the infarcted patients had got more than 80% stenosis. 68% of those people with infarction, they had less than 60% stenosis. And that is true in all the four studies. And the meta-analysis of all the four studies also proved that. Now, the message here is, it is not the degree of stenosis that is important. It is the type of plaque that they harbor and the risk profile that they have and the risk behavior they are undertaking, which will lead them to acute coronary event. The red color is less than 50%, 50 to 70% is the blue color, more than 70% is the yellow color. So hardly 14% of the people only had more than 70%. 60, and 50, less than 50% stenosis is there in 68% of the people. This message must be understood by all clinicians. Just don't go by the coronary vascular lumen size. Coronary vascular lumen size is not the denominator which decides the fate of the patient. Of course, it is important if there is 100% occlusion, you relieve it. But having said that, any 70% stenosis or 60% stenosis, well-controlled risk factors can manage, versus another patient who has 30% or 40% stenosis, very poorly controlled diabetes, very dyslipidemic, smoker, elderly, he has got a greater risk of dying of acute infarction very soon. Next one. Not the degree of stenosis. This you have to understand. Next. Now you see, I told you, the patient is there, or you are there tomorrow, you are 40, 50, then you say, do I have any plaque burden in the body? If it is so, is it a vulnerable plaque or is there a non-vulnerable plaque? Is there a way of knowing? Yes, we have a way of knowing. First one you see, plaque formation, indicated marker is total cholesterol, LDL, LPA, SLDL. That means every patient you are evaluating, you must measure the TC, LDL, LPA, and SLDL. These are direct indicators of plaque formation. Plaque formation is not plaque rupture. Plaque formation is a potential for danger. Okay, now vulnerable plaque, inflammatory plaque, multiple risk factors, infections. Can I measure it? C-reactive protein, adhesion molecules, ICAM, CCAM, interleukin 6, tumor necrosis factor alpha, SCD40 ligand. These four, five or six tests tell me whether there is an inflammatory process going on. Then, is there a plaque rupture? Do I know whether there is a plaque rupture is there? MDA, modified LDA, macrophages and metalloproteases are also released. Then finally, if the plaque ruptures, platelet thrombin microemboli are going on, how do I know that the microembolization is occurring? D-dimer, complement, fibrinogen, troponin, CRP, CD40L ligand. These are the markers of thrombosis. Now, if you want to know plaque formation, that is the test. Plaque inflammation, those are the tests. Plaque rupture, that is the evaluation. Thrombosis, these are the evaluation. Who is measuring? Just chest pain is coming, and somebody is going to go to angiogram, the cardiologist, 30%, 70%, some put some tube, get that. But we are not interested in modifying the risk behavior by classifying the patient according to the state, whether he is in the stage of plaque formation, plaque inflammation, plaque rupture, and acute thrombosis. We need to classify those patients. Next one. New markers of CHD. Already we discussed these things. Markers of plaque formation, LDLC, LPA, homocysteine. None of us are measuring the homocysteine. It is a treatable risk factor. You just give folic acid, homocysteine will come down. Markers of inflammation, vulnerable, HSCRP, SICAM, soluble intracellular adhesion molecules, interleukin 6, tumor necrosis factor alpha, serum amyloid alpha, and serum CD40 ligand. These are the markers of inflammation. Next slide. Markers of plaque rupture, whatever there in the diagram only I am putting here. MDA modified LDA or oxidized LDL, MMPs, that is matrix metalloproteases, SICAM, and soluble intracellular adhesion. Markers of thrombosis, D-dimer, complement, neopterin, fibrinogen, troponin, CRP, LDL40 ligand. Today, a clinician, if he wants to classify the patient, is it process of plaque formation, plaque inflammation, plaque rupture, and thrombosis? This can be categorized clinically. Next one, the pathogens is over. Now we go to acute coronary syndrome, clinical classification of acute coronary syndrome. Next one. What is the spectrum of CAD? CAD is not one disease. It is a spectrum, big spectrum. What is the spectrum? Normal individual, asymptomatic coronary artery disease, chronic stable angina, then click. Then you have got unstable angina, NSTMI, STMI, reinfarction, sudden cardiac death, cardiovascular mortality. Okay, what are the stages now? A normal coronaries, asymptomatic CAD, CSA, chronic stable angina, unstable angina, NSTMI, STMI, recurrent MI, and finally, sudden cardiac death and cardiovascular mortality. This is the spectrum of the disease. Once we see the patient, we must know where he is, whether he or she, whether she is normal or STMI or asymptomatic or CSA or unstable angina, we have to diagnose them. Next one. Important distinction. This is a very important slide. Now you see. If you take the community of people who are developing coronary artery disease, there are two groups of patients. One group of patients, the disease is very slowly progressive. CSA, crescent angina, unstable angina, NSTMI, STMI, cardiovascular mortality. A long rope is there. There's 40 years, he has got angina, 50 years, unstable angina, then he goes to STMI, and then warning signs are very much long duration. What will the advantage? Collateral blood flow has started. Usually elderly person. CAG will not confirm CAD. If you do a CAG, all the vessels, they say normal, 50 less than 50%. Prognosis is good. Elderly patient, non-vulnerable plaques, full flow limiting narrowing forms only 30% of the cases of myocardial. This is this is called one phenotype. One type of presentation is this. A person who has got angina, slowly unstable angina, then NSTMI, STMI, warning signs, long duration, collateral blood flow, ECG, TMT is positive, CAG is negative, prognosis is good, older patient, non-vulnerable block, flow limiting narrowing. And if he is at rest, he can manage the life without anything, without exerting himself. He will not have symptoms also. Forms only 30% of the case. Unfortunately, in India, we have 70%. Next click. 70% of the patients they go to the other group with sudden major acute coronary events. They give no time to act. Very nice, sir. Last night he had a very good dinner. He ate chicken and double masala dosha, everything. Today morning is no more, sir. Did he ever come to theater? No, no, sir. He dropped down in the theater, sir. He has not given any time, sir. This is the presentation. We had our Venugopal who died in the theater. This type of patients are 70% of the patients are like that. No previous CSA, no chronic stable angina, no unstable angina, no warning signs, short duration, no time for collateral blood flow. TMT and CAG are negative before the MES. Yes, sir, he underwent TMT also, sir. 1 week back it is negative. Angiogram last year was negative, sir. 6 months back he is all right. Now he died because prognosis is poor, younger fellow, vulnerable block, focus on the factors causing the rupture, contribute to 70% of the MI case. This dichotomy, if you don't understand, you will never be able to give proper treatment for a case of coronary artery disease. So what I suggest is all of you should keep in picture whether the patient I am dealing, does he belong to the green type or to the orange type. Orange type is dangerous fellow, green type relatively better. Both are disease only, but we have to classify. Next. What I have to do then? I have to ascertain the pretest probability of the coronary artery disease. Pretest probability of coronary artery disease, number 1, age, number 2, gender, number 3, nature of pain, number 4, previous MI, 5, diabetes, 6, smoking, 7, dyslipidemia, and 8, resting STT changes are there or not. This is a small calculator. You just put these numbers into that age, gender, nature of pain, previous MI, diabetes, smoking, dyslipidemia, resting STT changes. If you put that, you will get probability of CAD. So the score will come something like 10% probability, 15% probability, 5% probability, 80% probability. The answer will come once you have this. So now click that one. Next one, the clinical presentation. CV risk factors are there. They derive the pretest probability. When you derive the pretest probability, less than 15% the score has come. No testing is required because the probability is less than 15%. Intermediate probability 50 to 75%, stress testing is indicated. You have to do the stress testing. More than 75%, no requirement for stress testing. Already the probability is very high. You do an angiography and see. If you don't do the pretest probability, you will unnecessarily do angiograms for that 15% fellow. You will not do the stress testing for 15 to 75, and you will keep doing stress testing unnecessarily and causing risk for the 75% fellow. You have to decide whether you do a stress testing or angiography or no testing, depending on the pretest probability. It is dependent upon age, gender, all the factors which I have shown you in the previous slide. This is a computer model and giving you the pretest probability. Next one. Okay. Less than 15%, I don't test. Okay, very good. More than 75%, I do an angiogram. 15 to 75%, I am more interested. This is the fellow where I can pick up and give treatment and see that he doesn't progress. Assess ECG and exercise tolerance. Normal ECG is there. ECG I have taken, ECG is normal. Can he or she exercise? Is the knee joints okay and the obesity is not much? Patient can exercise, can at least walk for 7-8 minutes. Then you decide to do the exercise test. Then you do TMT test. There is what is called a Duke's score. I will show you what is TMT, and in that I will explain due score. And it is negative, then no more testing is required. Who is this fellow? 15 to 75% probability. ECG I have taken. ECG is normal and he can exercise. Treadmill I have done. Duke's score is negative. No more testing is required. Let us say ECG is normal, but treadmill shows positive result. Then he must go for angio. Okay, the other way around. Patient is abnormal ECG. It is ECG I took. ECG itself is showing some changes. Then why again doing a stress test? Is it a aspiration T inversions? There is no reason to do any stress test. And there is a risk of doing a stress test also. Once the abnormal ECG is there, then or a patient cannot exercise. Obesity is there is a knee joints are not working, and or a patient is having one limb amputated, only one limb is there, he cannot do exercise. Then you do MPI, myocardial perfusion index, or exercise stress echocardiogram, ESC, or chemical stress echogram. Please, above. Don't go fast. There. And finally, if any one of those tests are positive, angiography. So what did I do? First I did a pretest probability. Pretest probability less than 15%, no cardiac evaluation. More than 75%, none of these things. Straight away go for the angiogram. Okay. Now it is 15 to 75%, assess the ECG and exercise tolerance. ECG normal, patient can exercise, do a treadmill. Treadmill positive, go for angiography. Treadmill negative, no more testing. ECG itself is abnormal, no treadmill testing. Do MPI, CSC, or ESC, that is chemical stress echo or exercise stress echo or MPI, and then do an angiography. This is the procedure how you have to go. Next. Now, what are the three types of diseases spectrum I have got? Unstable angina, NST, EMI, non-ST segment elevation, myocardial infarction, and ST segment elevation, myocardial infarction. Basically, the spectrum is comprising of three areas: unstable angina, NST-EMI, STMI. Why I need to know them? They are clinically different, pathologically different, treatment-wise also they are different. The treatment I give to an unstable angina is very different from the treatment of NST-EMI or STMI. Next slide. What are you seeing? Next slide is acute coronary syndrome, ESCS. That is the title, isn't it? No ST elevation. Okay. Looked at the ECG. There is no elevation. Or there is ST elevation. Basically, NSTE, STE. STE is ST elevation. NSTE, no ST elevation. NSTE can be two types. No elevation of ST, but there is a subendocardial infarction. That's called NST-EMI. Or there is no infarction, only a ST segment elevation, unstable angina. Whereas you go to the other side, non-Q-wave myocardial infarction and Q-wave myocardial infarction. What are the four entities we have got? Unstable angina, NST-EMI, STMI. So, what I did the ECG. ECG, no ST elevation. It could be unstable angina or NST. And if there is an ST elevation, is it non-Q-wave or Q-wave myocardial infarction? Next one. The relative burden. Acute coronary syndromes, let us say 101.5 million hospital admissions are followed in this study. 1.24 million are unstable angina or NSTMI. Only 0.33 per admissions per year are STMI. That means they have got a scope to do something for this 1.24 and prevent them to going into a full-blown ST segment myocardial infarction. The burden of unstable infarction, unstable angina, and NSTMI is much more, 4 times more than the burden of ST segment myocardial infarction. This is from the studies we know, those two studies have shown. Next one. Now, the relative proportions of each one. 60% is USA, unstable angina, 27% is NSTMI, and 13% only is the STMI. This is a relative proportion. Now you go. This is pathologically, how do I understand? So you see the first vessel there, blue is very much there. Small red thrombus is there. Patient does not have some sort of anginal pain, but if there no occlusion, the drops are not elevated. This is unstable. The second one you see, uh, where you have got the thrombus burden is there, but still lumen is there, no total occlusion, patient is in the NSTM. And the third one you see, there is near total occlusion is there, and this near total occlusion is causing the burden there as the myocardial infarction. And finally, complete occlusion, Q wave myocardial. Previously, we used to call as intermediate coronary syndrome, non-Q myocardial infarction, Q wave myocardial infarction. Those technologies are now washed out. We don't have to use those intermediate syndrome and all that. We don't have to use. What we have to use is it ST elevation or non-ST elevation. If ST elevation is not there, if it is NSTMA, is it unstable angina or NSTMA? These are only three categorizations we require. And you can see pathologically which is what. The first one is 90% lumen is open, little thrombus burden. The last one is 100% thrombus burden and the lumen is not available for opening. Next one. Next one is unstable angina, NSTMI. Click. So we have now moved from the cardiometabolic risk, atherosclerotic vulnerable plaque, pathogenesis of ACS, ACS clinical classification, and we have now come for the unstable angina and NSTM. Let us just look at a few slides. Now, next slide. These are NSTA, no ST elevation, lumen is preserved. The lumen is totally blocked by thrombus, ST elevation, acute coronary event. Presentation working diagnosis, ACS. Patient is admitted, symptoms are suggestive of ACS. What ACS? Is it unstable angina or NSTMI or STMI? Then ECG will decide. Then immediately you do an ECG. ECG showed no ST elevation versus ST elevation. Then you do a trop there. If you do a trop is elevated, ST elevation is not there, that is NSTMI. Trop normal, no ST elevation, no ST elevation, that is the unstable angina. And ST elevation is there, that is the full-blown ACS. Cardiac biomarker you have. Working diagnosis with symptoms, ECG, biomarker, final diagnosis. Final diagnosis based on unstable angina. Patient is symptomatic, chest pain is ongoing, not resolved by nitroglycerin. There is an obstruction going on. There is no evidence of ST elevation. Enzymes are also not elevated. Unstable angina. Second one, patient is having ongoing chest pain and ST elevation is not there, but then the troponins are elevated. He is having non-Q myocardial infarction, also called the NSTM. Finally, a patient is acutely having pain and the enzymes are very much elevated. ST segment is very much elevated in the ECG. That is a ST segment elevation myocardial. So what are the four things? The symptomatology for working diagnosis, the ECG, the biomarker, and classify them into one of the three groups. Why? Because my treatment is different for each of these three groups. Now go to the next slide. Chest pain. Patient has come for chest pain. All chest pain is not myocardial infarction. It could be so many things are there. Non-traumatic chest pain only you consider. Somebody has got an injury to the chest, he complains of chest pain. That is not myocardial infarction. Young fellow, 5-year-old fellow comes from chest pain. He is not going to have myocardial infarction. You should have a working suspicion of acute coronary syndrome. This is called the working diagnosis of acute coronary syndrome you made. Then what did you do? ECG you did. First step you did. Persistent ST elevation, ST segment abnormalities plus or minus, normal or undetermined ECG. Three things can come. ECG is either normal or I can't classify properly. There are some non-specific changes. Or there are STT changes are there. Or there is a persistent ST elevation. If it is ST elevation, don't do any drop, keep. Nothing is required. He is already having ST segment elevation myocardial infarction. Reperfusion. Immediate procedure is reperfuse and then save him. Don't waste time in doing this test, that test, unnecessary test. Of course, diabetes you have to monitor, BP you have to see, and straight away take him for reperfusion. Whereas a fellow with normal ECG, Troponin done, repeated after 12 hours, that also negative. He can be discharged. Very low risk patient is unstable angina. Conservative management doesn't require admission even after 12 hours. Only observation for 12 hours to repeat the drop. First drop is negative. Don't be sure that it is not disease. Wait for 12 hours. Again repeat the drop and ECG. If they are still normal, then send him. ST segment abnormality says that drop is positive. That means he should not be perfused because it is non-ST segment infarction. ST segment infarction should be perfused. Non-ST segment infarction should not be perfused. The treatment is different. Unstable angina need not be admitted. So treatment is different. Unstable angina fellow can be managed in the OP basis or in the observation itself and he can go. Whereas NSTMA patient should be admitted and not thrombolized but treated aggressively. STMI admitted, treated with reperfusion. Okay. Now let us see the next one. 5 causes of PSCS. What are the 5 causes? Thrombus, secondary unstable angina, mechanical obstruction, dynamic spasm or obstruction, inflammation or infection, increased demand due to any cause. Patient is normal, suddenly the demand is more for some reason, then the ACS is precipitated. Mechanical obstruction, dynamic obstruction like vasospastic angina, inflammation and infection, and increased oxygen demand. These are the various. And now, how do I go about? Next one. Next one. History and physical, 12 lead ECG, right ventricular V4 also is required. Never forget to take RV4 because right-sided infarctions will be missed if you don't record RV4. And look for cardiac biomarkers also. History physical, 12 lead ECG, right ventricular lead, cardiac biomarkers are the important 3 steps that you do. Next one. Presentation of unstable angina. Occurring at rest. What is unstable angina? There is no exertion. You got the angina at rest. It is prolonged. Normal angina is 3 or 4 minutes. This is more than 20 minutes. The pain is persisting. Rest angina. New onset angina. And then more frequent, longer, lower threshold. Crescendo angina. It's increasing. And angina equivalents like in women, diabetic people, old persons, CKD, postmyocardial infarction. These are called coronary equivalents, angina equivalents. So if you see any one of these people, even minor symptoms or vague symptoms also should be considered as angina only. They may not have chest pain, they may have dyspnea alone as the presentation symptom, particularly in women myocardial infarction, in diabetics, in old people, in people with CKD, and people who have post-myocardial infarction. These are all the various angina equivalents. Next one. Symptoms. Classical central ischemic chest pain and impending doom and pain, heaviness in the arms, usually left elbow or finger, discomfort in the neck, jaw, back, retrosternal epigastrium, autonomic upset, sweating, vomiting, nausea, inferior myocardial. Somebody is presenting with vomiting and nausea and myocardial infarction. Most likely it is inferior aortic. These are the symptoms on the left side. Go to the right side. Autonomic symptoms, increased heart rate, blood pressure is varying, sweating and pallor, exacerbating factors are there like anemia, hypertension, cyanosis, fever, signs of complications like LVF, left ventricular failure, arrhythmia and hypotension should be thought of, and murmurs of AS, that is aortic stenosis, hypertrophic obstructive cardiomyopathy, HOCM, carotid bruit, and vascular disease may be there. Okay. We'll probably hold here.